Hello everyone. Oh god, I'm really not ready for this video actually. Hello everyone. Today I'm going to be going through drugs and how they treat schizophrenia. So this is the I don't know what is it now, the fourth bullet point I think it is of schizophrenia. A relatively straightforward one. It's basically how drugs. There's a lot of different types of drugs, isn't there? Looking at that picture, that's quite an ill individual. Um, But specifically, we're going to be looking at antipsychotics and their treatments of schizophrenia. Now, you need to know two types of antipsychotics, and they are typical antipsychotics and atypical antipsychotics. But when it comes to any drugs that you have to think about, so if you remember from your first year, you had to know SSRIs and their treatments of OCD. These are the five main things I would argue you need to know about the drugs to be able to outline them and evaluate them as well. So, you need to know how the drug actually technically works. What is the process? What's the mechanism for how this drug works? What does it do? You need to know the side effects of the drugs: neuroleptic, malignant syndrome, weight gain, dry mouth, sexual problems, so on and so forth. You need to know how good the drugs are. It's pretty key, isn't it, to know how good the drugs are? So I would argue you need to know some statistics about how effective drugs are in the treatments of OCD or schizophrenia or addiction, etc. You need to know the half-life of the drugs. I'm going to probably go into the half-life of the drugs here, as well as any evaluations for drug therapy, of which there are some main ones. So let's make a move. Today we're going to be looking at antipsychotic drugs, right, and how specifically they alter the neurochemistry, particularly the dopamine within the brain, although sometimes serotonin, glutamate, other ones as well. So we're going to be looking at typical drugs such as chlorpromazine, and we're going to be looking very briefly at atypical antipsychotics like clozapine, as well as some others as well. Now, one thing to note straight away that I'm sorry, this isn't the thing to note, but I've just had loads of crackers because I'm so badass. And they're still in my teeth. So sorry about that. One thing you need to know, is this drug treatment has specifically come from the dopamine hypothesis. So it has been created with the dopamine hypothesis in mind. So you do need to have an understanding about how the practical applications, we can see the practical applications of the dopamine hypothesis. The very basics, but let's start with typical ones. I like these ones. You shake them. They're like little mini maracas. Anyway, sorry, this has been a terrible start. Typical antipsychotics came about in the 1950s. One thing to write down is that they were the first wave. They were in the first wave of antipsychotic drugs that came about. They were one of the first drugs created, and they were largely aimed at tackling the positive symptoms of schizophrenia. Now, how they worked is they acted as what's called an antagonist. So what they did is the drug molecules would come in and they would sit in the dopamine receptor, essentially blocking it from any dopamine entering in it. If the dopamine isn't entering the receptor is useless, and therefore you're not getting that. Because remember, the problem with schizophrenia in the first place is that there's too many receptors. If you block some of those receptors, you're essentially meaning that not all the receptors are working, and you're reducing down the amount of working receptors to that of a neurotypical individual. So this is essentially what is happening. You've got the postsynaptic one down the membrane down the bottom. You've got the presynaptic membrane, and then essentially what would happen is, as you can see here, I'll just go back in case you didn't see that. There you go. Can you see that? Do you see it yet? Do you know what it is? Sorry, that's Rolf Harris. That's quite inappropriate. But essentially what they would do is they would block these receptors, meaning that when the dopamine came out, it would only be a couple of receptors that would be able to actually work. and for some reason, this seems to have an effect. Now, I think that's amazing, by the way, the fact that we can create drugs. How good are we? How good are, let's say we, how good are some intelligent humans that we've been able to create this therapy from a theory? It's phenomenal, really. However, the one thing you do need to know is that there are massive side effects to both typical and atypical. But let's start with the typical antipsychotics. So you have two different types of antipsychotics here, two different types of typical antipsychotics. You've got the anticholinergic. So the side effects from that. Now, before I read this out, even though you can read it yourself, this is a really, really important question to ask yourself. Are the cost of these side effects worth taking the drugs? Or would you rather just stick with schizophrenia? Dry mouth, urinary problems, constipation and visual disturbance with adrenergic, low blood pressure, sexual dysfunction, nasal congestion. One thing to please absolutely note down is actually, for some people, the cost-benefit analysis of taking these drugs, it would probably cost the people more to take the drugs, both financially and side effects, than would be worth it. So that's a really, really important question to answer, which we've got coming up. Atypical antipsychotics typically came about in the 1990s, by the way. It's a really important thing to write down because I don't think I've got it on here. I think I've got it as 1970s, but it's not, as 1990s mainly. But these drugs work on not just dopamine, but they also work on serotonin and glutamate as well. So the problem with, if I go back, the problem with typical antipsychotics, and again, write this down, is they typically only tended to work with positive symptoms. They didn't tend to tackle the negative symptoms. But actually, atypical antipsychotics do work on the negative symptoms, because remember what serotonin is for? You know, it's for mood, etc., etc. Well, one of the negative symptoms of schizophrenia is low mood. It's that very depressive state that schizophrenics get put into. So not only do atypical antipsychotics work on the positive symptoms, but they also work on the negative symptoms as well by reducing the depression, improving the anxiety, as well as the general cognitive function of the patient. But they generally work the same way as the typical antipsychotics, so they just sit in the receptors. Now, the one thing to keep in mind here is that I feel like I keep saying write this down, when you should be writing it down either way, but I just want to make sure you are. So write this down. Antipsychotics work quicker than therapy. So that is why you would give drugs to a suicidal schizophrenic first. You would not get them into therapy, right? And the whole point about being suicidal, by the way, is that you're generally quite severe, and therefore you're not want to go to therapy anyway, because you're far gone past that point. Far gone past that point. It's been a long day. Shut up. So these are some other examples about atypical antipsychotics. So I guess it's worth noting that clozapine that I mentioned, the NICE guidelines actually say that you can only give clozapine if two other atypical antipsychotics have failed. So I don't know what the most common one is off the top of my head. I think it might be risperidone. I think risperidone is the most common atypical antipsychotic. That's the one that like if you have depression, you get given sertraline or fluoxetine. That first defense against it. Risperidone is probably the first defense against it. Now, if risperidone fails and olanzapine fails, then you'll be given clozapine. So one thing I do want to go into again is side effects, which is quite important. I don't know if I've actually got, no, I do want to go into, ignore that. Side effects of and atypical antipsychotics are actually quite bad there are fewer of them, but they are quite bad. So if I come off this and if I go on here and I type in bloody hell, falling over myself here, neuroleptic malignant syndrome. If we just have a look at what neuroleptic malignant syndrome actually is, it's a rare but life-threatening alarm bells. Is it worth taking the drugs? Yes, you have schizophrenia, and yes, that is bad, but is it worth losing your life over? I'm not entirely sure it is. So it's a rare but life-threatening idiosyncratic reaction to a neuroleptic medications characterized by really bad fever, muscular rigidity, altered mental status, which is what you're taking the drugs for in the first place, by the way, because you have an altered mental status, and autonomic dysfunction, like i.e. central nervous function dysfunction. Your heart you start to get arrhythmias, for example, palpitations, loads of heart issues. So again, what I'm trying to get across here is that depending on the side effects will impact what your cost benefit analysis is of actually taking the drugs. Is it worth taking the drugs? Is it actually worth taking the drugs? The other thing I do want to go into whilst I have you here is just to say half-life of, let's say clozapine, right? The half-life of clozapine. Now, what exactly do I mean? What exactly do I mean by half-life? It's a bit confusing, but I will go through the very basics of it. Half-life is how long it takes for half of the drug to leave your system, right? And thus not be affecting you anymore. For example, the half-life of paracetamol is 4 hours. But please don't fall for the misconception that, it then takes 8 hours for all of it to get in. The whole thing about drugs is, it, as you can kind of see from this, it takes the first half of the drug, the first half of paracetamol, 4 hours to leave the system, but the second half breaks down very, very quickly afterwards. So when we say half-life, we're meaning, kind of how long it stays in the body. So if paracetamol is 4 hours, it appears a single dose of clozapine is 8 hours, but you typically get given 2 doses. So you typically will get given like a 150 milligram dose. So that's 16 hours. 16 hours that the drug will take to get out of your system. So essentially, that's why you take one antipsychotic a day. Is because it takes 16 hours to get out of your system. You then have 8 hours sleep. And by this point, by the time you wake up, the drug is actually quite out of your system. You then have to take another one. So why is this important? The drug or antipsychotics will only work for as long as the drug is in the system. It's not like CBT where you can learn it, go away, and still have that treatment going. The drug will only work for as long as it's in the system. And that is a massive, by the way, Jesus, don't mean to do that. That is a massive evaluation, that the drug will only work for as long as it is in the system. So Davis, does it work? Let's have a look at the effectiveness. Davis performed a meta-analysis and found that actually the drugs compared with placebos, this is typical antipsychotics. Typical antipsychotics were more effective with 75% of sufferers, right? So therefore, there is a difference between the drugs and placebos, right? You hopefully will know what placebos are. Why am I doing this? There we go. Oh my God. Okay, so Lieberman is a fantastic piece of research though, because it kind of says, wow, hold on a second. Although it is effective, who cares if the side effects are so bad that people stop taking it anyway? So Lieberman compared the effectiveness of typical and atypical when 1,400 patients and found 74% of people discontinued their treatments because the side effects were so bad. What is the point of taking drugs that work if the side effects are so bad you stop taking the drug? There isn't any point. So that's massively concerning, by the way, right? Discontinuation rates and times were similar for both types, although for different reasons. Atypical tended to be with muscle disorders, which, let's face it, would put you off. If your arm was just doing that and you didn't tell it to, for example, or if you start like twitching, for example, then yes, you are probably going to be very conscious of that and you're going to stop taking the drugs. On the other hand, typical drugs were linked to weight gain, which is actually, I guess, unsurprisingly, a massive factor in people stopping taking drugs. Um, there are a lot of drugs that make you put on weight very quickly because they suppress the metabolism rate that you have in your thyroid, and then you put on weight just by looking at food. Now, in terms of evaluation, there's a few points here. I will go through these because I think it's important. I think drug therapy is probably one of the easiest points to actually evaluate. The first one here, is it effective? Yes, it is. Look at Davis, for example, right? But also bring in side effects. Now, there are a few side effects I didn't go through, for example, tardive dyskinesia. I always struggle to say that. Have a look at what that is. That is, well, it kind of says it on there, to be fair, involuntary muscle movements. But what I was going to do, these two are quite key. Why don't you compare either typical to atypical or just antipsychotics to CBT? I've got a model answer in a second for it. This one down here, I definitely want you to make a note of. Right. The great thing about drugs is that they massively improve the quality of care. It allows people to live independently, which may reduce the impact of expressed emotional families. If you go back to expressed emotions, may prevent relapse, so on and so forth. But it does give people independence. It does give people a great quality of care. So in terms of model answers, I've written two. This one is just a normal model answer. The next one I'm going to do is a comparison point. But a model appeal here, an issue with drug therapy is the level of side effects. Boom, that's my point. What's my evidence? I.e., what are the side effects? For example, atypical drugs have, such as clozapine, have side effects such as weight gain, hyperprolactinemia, which is basically breast milk production in men and women, by the way, dry mouth, and sexual problems. Very different side effects there. So that's my evidence. Now I need to go into why that is important. Why is it important that these drug therapies have side effects? Well, Kieran, these side effects counter the effectiveness of the drugs, as sufferers may deem the cost to be too high despite how well the drugs actually work. And this is going to lead to a knock-on effect of high discontinuation rates, use that term please, which would have severe economic consequences on local health services. If you've got loads of people who are schizophrenic who are not taking their medication, somebody somewhere is going to get hurt sooner rather than later. Therefore, for the continuous treatment of schizophrenia, it's likely that the next generation of treatments will have to have fewer side effects. Now, that is a fully structured point. It's got evidence, it's got an elaboration about why, it's got a link back which is different. I've also got a model comparison here. Now, these are easy. Sorry. These are very, very easy. I'm going to compare drug therapy to, I think it's CBT in this case. A difference between drug therapy and cognitive therapies like CBT is the time in which they take to start being effective. Boom. Now what I need to do is slightly different. I need to give evidence for one and evidence for two. So I'm going to start it by saying, on the one hand, ready, wait for it. On the one hand, atypical antipsychotics generally begin to work within 4 to 6 weeks, allowing for a shorter time period between diagnosis and recovery. Now I need to give the evidence for CBT. Well, on the other hand, CBT can sometimes take as long as 16 weeks. Whilst recovery is more permanent under CBT, there is a longer gap whereby sufferers have to experience intense symptoms. Therefore, drug therapies seem to be more ideal in the short term to address symptoms. In terms of how this question comes up, you have a question just here and more likely here. But that is pretty much drug therapies for schizophrenia. If I go back to the beginning, I'm hoping you are going to know all of what I have mentioned before, in that you need to know how the drug works, where the dopamine sits in the receptor and blocks it off. You need to know the side effects for both typical and atypical. You need to know how effective they are. So no statistics for both. You got that 75% for typical. How type into Google for a statistic, how effective are atypical antipsychotics? Half-life, easy, 8 hours, 16 hours, roughly speaking. And you need to know evaluations of therapy there as well. Relatively straightforward one. Make sure you've filled in your workbook and made your flashcards, and you will have completed this.